What does it actually take for a hospital, a research institution, or a public health agency to deserve the trust of the communities it serves? That is the question my guest has spent her career trying to answer. Not as a philosopher, but as a physician who sees patients, and as a researcher who has built the tools to measure whether trust is actually there or not. Consuelo Wilkins is Professor of Medicine and Senior Vice President at Vanderbilt University Medical Center in Nashville, Tennessee. She led the development of Vanderbilt's Racial Equity Plan, and her research team created one of the first measurement tools designed specifically to capture how communities that have historically been excluded from medicine actually perceive trustworthiness, with findings that are difficult for any institution to ignore. In this conversation, we talk about what it feels like to sit across from a patient who does not trust you, why institutions so often respond to broken trust with the wrong remedy, and what the COVID pandemic revealed that was hiding in plain sight long before any of us had heard of it. Consuelo, welcome to TrustTalk. You are a physician, you see patients, and somewhere along the way, studying trust became central to your work. I want to start with that moment, or that realization. When did you first understand that trust was not just a backdrop to medicine, but the thing itself?
Well, thank you so much for the opportunity to speak with you. I would say that it wasn't an all of a sudden pivotal moment. It happened in layers. Growing up, even before I became a physician, my experience was coming from a community that didn't necessarily have the best access to care. So there was always this more of a dance and understanding with healthcare in general. But as I moved into the professional space and became a physician, it became more clear that trust and being trustworthy were really critical to being able to communicate with patients and their families. So people might be more likely to accept that you have the credentials, you have your board certification, you have the knowledge that's necessary to provide the care, but whether or not they act on your recommendations and whether or not they return for their follow-up appointments all often was closely linked to whether or not they had a relationship with you, whether or not they believed that you believed in them. And underpinning all of that is really whether or not they trusted you. And of course, the relationship inherently between a physician and a patient is often one of a power imbalance. And so they're putting their lives literally into our hands. And it's so important that they actually feel like they can trust us in that setting.
Did your colleagues see it the same way, or did that feel like a lonely observation at the time?
I wouldn't say that it's something that I necessarily, at least early in my career, talked with my colleagues about. I don't even honestly know that I would have framed it that way early on, that trust was really such a big piece of the issue. It was probably more ineffective communication, or how can we actually get people to adhere to their treatment, and less of an inward reflection to maybe there's something related to being trustworthy or understanding that they need to trust us.
In your research, you make a sharp distinction between trust, mistrust, and distrust, and you argue that mixing them up has real consequences. If a community has specific, experience-based reasons to be suspicious of a hospital, and that hospital responds with a general trust-building campaign, it actually makes things worse, because it feels like the institution is trying to charm its way past a real grievance rather than address it. As a physician, how do you make that diagnosis? Which problem are you actually dealing with, and what does the wrong treatment look like?
Often, I think we probably just need to be clearer in which one of these concepts we're talking about. Are we talking about trust? Are we talking about distrust? Or are we talking about mistrust? So if a community is concerned about trust and whether the organization is trustworthy, and the response is some glamorous ad campaign that isn't addressing the underlying historic injustices that the organization has participated in, then it really doesn't matter whether it's trust, mistrust, or distrust, because the organization isn't really addressing the underlying issue. And so I think it's probably more nuanced than that. But sadly, I would say that in my experience, what you described has happened much more often than it should, that organizations are wanting to bypass the need to repair these underlying issues and their past relationships with the communities.
When you encounter someone and you can feel that they do not trust you, I mean, not you personally, but the system you are part of, the white coat, the institution behind you, what goes through your mind? And what do you think goes through the minds of most doctors in that moment? Do they see a difficult patient, or do they see something they themselves may have caused?
Yes, so I think this is challenging. So I try to be in tune when I am interacting with a patient or their family, just to be aware of anything that feels like unease. And so often when that's the case, it's not clear what the underlying issue is. Is trust or mistrust or distrust the issue? Or are they uneasy because they don't understand what I'm talking about? Am I using too complex of language? Am I not explaining it well? Are they just challenged because of their health? Is this a difficult and challenging setting for them? But usually, whenever that happens, when there is this unease, I try to tap into my humility, which I know can be challenging for physicians. Some might say that. Some might say that. I try to tap in and just leave space and open the door for whatever is the cause, whatever is contributing to this unease. And if a person says they don't know if they can trust me, or they don't know whether or not I'm the right physician for them, then hearing that, I think, is important, and talking through that. So I actually find that having the open and honest conversation is really key to moving past it. I'm not sure that most physicians are aware or are thinking about trust, except recently, of course. In the last few years, especially since the COVID pandemic, issues around trust and mistrust and distrust have been more at the forefront. And the fact that people, especially in the United States, are less trusting of science and of healthcare has been something that we've talked more about. But I would say that in general, I'm not sure that most physicians are thinking about it.
Is that, by the way, something you can teach, or does it take years to learn to see it?
I think you certainly can teach it. It's probably more nuanced, though, in terms of recognizing it, especially in the setting of what we're seeing nowadays with shorter visits with patients, less time to actually interact with them. And so all of the things that we're trying to now cram into a very short clinical visit, we are often rushing past some of these cues that patients and families might be giving us.
When an institution loses public confidence, the reflex is often to say the public has been misled, or does not understand the science, or has fallen for misinformation. You take a different view. What does that framing miss? And what does it cost an institution to get that wrong?
I absolutely take a different view. I think that we should always be turning the mirror towards ourselves and reflecting on what our role is in maintaining public confidence and trust, and also deeming ourselves to be worthy of trust. And so for me, the focus should be on trustworthy. Are we actually worthy of people's trust? What have we done to demonstrate that we are worthy of trust, as opposed to expecting that people should trust us without any demonstration of or any evidence of our characteristics here. And so my approach is more of the, what are we doing? Have we clearly communicated? Are we addressing their underlying concerns? Are we hearing what their priorities are? And who is responsible for sharing the evidence and the information? The creators of it, the researchers, the healthcare professionals, the public health agencies. It is our responsibility to do a better job there.
And have you seen an institution actually make that shift, genuinely accept that it was the problem?
So I think this is challenging to say from an institutional standpoint to make that shift, because who are we as an institution? A collection of individuals. And so often this requires there to be some executive leadership, or the senior leaders are taking the stance and taking some ownership around it. And then it's cascading down. But it really does require that there's an investment and buy-in, I think, at the highest levels of leadership, and then a plan to make sure that everyone else can align and get on board with that. I have seen organizations do this, but I would say that a mistake is often that we presume that it's static or that it requires one shift. And it's really a continuous process. So you can't just make the shift and proclaim, again, that you've tried to repair a relationship or that you're hearing the public and you're moving forward. It's an ongoing commitment. And I think that's where I've seen institutions and organizations fail. And that's, again, probably something that we saw a lot of during the pandemic, so in the last 5-6 years, where people have, organizations and leaders have made commitments and put in resources and had campaigns, and even some issued apologies for their past actions. But their actions moving forward haven't necessarily remained aligned with that.
Trustworthy sounds like a quality an institution simply has, a label one earns. But in your writing, it sounds more like something that has to be demonstrated again and again, a practice rather than a property. You led the development of Vanderbilt's racial equity plan, which is exactly that kind of effort. What does an institution actually have to do, day to day, to deserve that word? And if you're looking back at the plan, which sits right at the heart of the debate around diversity, equity, and inclusion, where did the hard work really lie?
Yes, thank you so much for asking these questions. First, I would just emphasize that where I think many of us as individuals and also as organizations go wrong is we disconnect trustworthiness from trust. We want people and the public to be trusting, but we must first recognize that being trustworthy is an antecedent to trusting. So if you're not worthy of the trust, then we should not be expecting that people or the public are trusting of us. And so I think that's where I land with what are the qualities of the individual as well as the qualities of the organizations, institutions, and systems that demonstrate that trustworthiness. And so our racial equity plan here, just like many places, of course, in the last 5 or 6 years, have these plans. And a big focus for me and for our team was, how do we actually ensure that this work is actually embedded throughout the organization and a part of sort of the day-to-day practice? Because I think as long as it's seen as separate and isolated, it's more at risk. The people are less likely to recognize how it's connected to their day-to-day work, why it's relevant, and then we'll quickly go back into these spaces where we're no longer doing that work. And so seeing how all of these things are actually interconnected, I think, is how we continue to do the work long term.
Consuelo, I want to get back to what you just mentioned, the COVID pandemic. During that pandemic, trust in scientists, public health agencies and governments collapsed in many countries. You were living through that as a physician, seeing patients, watching it happen in real time. Was that a failure of communication, or did the pandemic simply make visible something that was already broken?
I think both. So I think that certainly what we saw during the pandemic was so much information that was being shared quickly, and this rapid need to understand how much information people could consume and how quickly they could do it, and not really being well prepared, I think, to communicate effectively there. But also, I would say that it wasn't just about communication. We did some things without transparency. And I think that when we consider what those characteristics should be or need to be of organizations and people in order to demonstrate trustworthiness, being transparent is high amongst those things. And so that's part, of course, of humility and integrity. But being transparent is high on the list of what people want to know, what's happening. And if they feel like they're uninformed or that we're keeping things from them, then it's really difficult for them to trust us or deem us to be trustworthy. And so I think we failed at many times to clearly communicate when we made mistakes, when we didn't know things, when we were still learning things like the science, the public health, the population health, the data. All of those things were rapidly evolving and required constant communication and also constant recognition of what we just learned that was new and why we changed our minds about this or why we were behaving differently.
You have built tools to measure trust, and what they revealed was striking. Black and Latino participants were not just less trusting, they were more actively distrusting. And the gaps showed up on very specific things. Fears about secrecy, about being misled, about their data being shared without consent. Why does it matter to be able to show that in numbers? What does a measurement tool force an institution to see that it could otherwise ignore?
Yes, so one of the primary reasons that I became more involved in doing work around trust and trustworthiness is less about my work as a physician and more about my work as a clinical researcher. So in clinical research, for my entire career, I have heard that some populations are less trusting or more distrusting, and that's an issue. And so I think of myself as a problem solver. Like, okay, well, let's fix these issues around trust and distrust. And so when I'm thinking about what are going to be our strategies or interventions to improve trust or decrease distrust, I need to be able to measure it. I need something to tell me where to focus and how I'm doing with these interventions. And so that's what led me and our team to focus on what are these tools. Now, there are actually quite a few tools. I'm sure you're familiar with them, maybe more of them than I'm aware of, especially outside of medicine and research. But there are these tools, but there were very few, and specifically in the space of clinical research. And so that's what my team and I wanted to focus on. But underlying both mistrust and distrust is often this connection to group experiences. So people like me, whether that could be people who are Black or African American, who in the United States are descendants of formerly enslaved people who are marginalized and minoritized in a different way, might have different experiences or beliefs than Latinx or Hispanic people in the United States whose history of injustice is more related to immigration and issues with more recent challenges. And so Sometimes people will lump all groups that have been marginalized into one, whether they're marginalized because of race, ethnicity, or because of socioeconomic status, or gender, or sexuality. They're all sort of put in one category, but because they may all be less trusting or more distrusting. But the reasons that they are less trusting are very different. And so if we're going to actually have interventions, then we might need to have different interventions. So again, if we're going to repair relationships with families and groups that are formerly enslaved people, then recognizing those research abuses that happen to Black and African American people for decades is really important there. And then if we're talking about repairing relationships or demonstrating trustworthiness to Latinx populations, then that means we need to recognize some of the ways that they continue to be marginalized around immigration and language and other issues.
Consuelo, we have reached our time limit for this podcast. Thank you very much for being our guest today, and I wish you all the very best and good luck with your further research. I assume you are doing further research in this area.
Absolutely.
Okay, good luck with that, and thanks for being my guest.
Thank you for having me.
Thank you for listening to Trust Talk. Trust is easy to praise, much harder to understand. That's what these conversations are for. Hope to see you back for the next conversation.